and thank you for joining us today. I would like to take this opportunity to welcome you to the Hartford Medical Society's lunchtime webinars. We are for a treat today to talk about COVID-19. How did we get here and where are we headed? And we want definite answers, or at least the best guess that Bill can provide. For those of you new to the Hartford Medical Society, we've been around since 1846. And our mission then is similar to our mission today, where we want to address the compelling problems facing medicine now and in the future. We want to promote collegiality among the medical professionals in our area, inform the Hartford community about medical challenges and solutions, and encourage interest in the medical humanities, especially near and dear to our hearts, the history of medicine. I'd like to also, while you're here, promote our April 6th big live event, COVID willing, with Dr. Ezekiel Emanuel. We're going to be at the Bushnell. HMS members are invited free with a guest. There will be food and drink before the event, so it's really a benefit for you to come. And we will have a long question and answer period with Dr. Ezekiel Emanuel, who is really one of the more impressive thought leaders in our industry today. I hope you can join us. But today, he said I should just refer to him as Old Bill speaking, but I think we'll do a little better than that. I am pleased to welcome Dr. William Schaffner. He is a professor of preventive medicine in the Department of Health Policy and professor of infectious diseases at the Vanderbilt University School of Medicine in Nashville, Tennessee. His primary focus has been the prevention of infectious diseases. He has worked extensively on the effective uses of vaccines and has been a member of expert advisory committees that establish national vaccine policy. He is committed to communicating about prevention to the general public, and we're happy that he is joining us. He has an extensive background in this. He graduated Yale in 1957. He attended the University of Freiburg, Germany, as a Fulbright scholar. He graduated from Cornell University Medical College, completed his residency training and fellowship in infectious diseases at Vanderbilt. He was also commissioned in the U.S. Public Health Service as an Epidemic Intelligence Service Officer with the Centers for Disease Control and Prevention for 2 years. He returned to Vanderbilt after that tour of duty and has extensive experience in this area. So to keep it short, so I don't embarrass Bill anymore, I welcome Dr. William Schaffner.
Well, Tessa, thank you very much. That was a very generous introduction. I'm pleased to be with you, and thank you also to Dr. Costo, who gently twisted my arm and persuaded me to join you today. I'm pleased to do it. And what I'd really like to do is offer an introduction and a little bit of the background, probably something we all know, but I'll try to organize it concerning Omicron and its predecessor variants, COVID, and then predict a little bit where we are today and where we might be in 6 months to a year. And then I'd really like to open it up to your questions. You know, all those questions you've wanted to ask, but haven't had the chance to do so. So let's start with the beginnings. These viruses are part of a family of viruses called coronaviruses. They're called coronaviruses because some of the early investigators looking under the electron microscope thought the construction of the virus resembled a crown, hence coronaviruses. These are mostly viruses that are out in the animal kingdom all around us. There are well over 25 strains of these viruses that have been identified, and there probably are more. 4 coronavirus strains have been adapted to humans, and we live with them in a very comfortable fashion. They produce mild illness, a common cold. They produce then, once we recover, an immunity that can last about a year, and then it begins to wane. And sure enough, down the road, we can become reinfected with that same strain. It's part of the reason that we can get recurrent colds over the years. It's important to note that their immunity, unlike the immunity we get with other viral infections, measles is a nice example, it's not permanent. Once you've had measles, back in the old day, once you've had measles, you were protected essentially for life. The coronavirus immunity is not nearly that durable. Well, against this background, all these viruses out there in the animal kingdom, on 2 previous occasions, these RNA viruses, which have the capacity to mutate, mutated such that they could infect humans. First, back in 2002, we had SARS, serious adverse respiratory syndrome. That came, we think, from animals in a wet market in China. Since then, investigators have traced the source of that virus back to bats. So bats are a great reservoir for coronaviruses. They get into other animals, mammals frequently, and then it jumped into humans, causing a very serious, highly transmissible disease, but one that required very close contact with people. And the sicker you were, the more likely you were able to transmit it to someone else. For a whole lot of reasons, many of which we don't understand, SARS receded and is not currently a problem anywhere. So that got quiet for a while. And then about 2010, a similar virus called MERS, Middle East Respiratory Syndrome, occurred in the Middle East with very limited spread around the world. And once again, it required very close contact to be transmitted from person to person. That virus, also thought to be acquired often from camels, had an ultimate reservoir, once again, in bats. So things were quiet on the coronavirus front until 2 years ago, when obviously, once again, a coronavirus mutated and developed the capacity to spread to humans. I'll pause here for just a moment, because as we all know, there's controversy about the origin of this virus. I think we could all nicely conclude, and the investigations have done this, this was not a virus released by malicious intent. That clearly did not happen. Would be foolish. You can't control this virus. It could go back and hurt the bad guys if it did, as well as the target population. So there's no malicious intent here. The only debate that remains is, did it come from nature? Or since there was a virus research laboratory in Wuhan, China, could there have been a laboratory accident that released this virus? That remains indeterminate. Let me just say very quickly, I'm in the camp of most of the coronavirus virologists who think it jumped from nature. But whatever the origin, we first assumed that this virus, as its predecessors, would spread slowly and require close contact. We were wrong about that. The epidemiologists, myself included, were outfoxed by this virus, because it turns out this virus, one of its characteristics was that it was a respiratory virus that could be spread extraordinarily readily, as most respiratory viruses are. Influenza, for example. And by the time we realized that, it really had spread in a matter of a couple of months to every continent in the world, except maybe Antarctica. And it was spreading widely. And so since then, we've been playing in one form or another catch up with this virus that has managed to stay a step ahead of us all down the road. Now, these viruses do have the capacity to mutate. Most of the time, these mutations are harmless. They just fall by the wayside. But periodically, you can get a mutation or, more recently, a whole series of mutations that critically alter the function and the nature of the virus. Just very quickly, as I'm sure most of you know, this virus can be considered akin to a tennis ball in its shape, with a series of projections that come out of its surface, the so-called spike proteins. These spike proteins are akin to the key that goes into a receptor site in the cell, the lock. That spike protein inserts itself, and that enables the virus to enter the cell, then hijack the metabolic machinery of the cell such that it reproduces itself. The virus then bursts out and reproduces that phenomenon, multiplies extensively, and can be transported to other organ systems in the body. It implants mostly back in the throat, up in the nasopharynx. It can multiply there and then be transmitted by the respiratory route. We think for the most of the time, very close in, 3 to 6 feet, with prolonged contact, prolonged is over 15 minutes, and more often indoors than out. Can it be transmitted more distantly by the airborne route? Can we exhale it and then have it float in the air more distantly, hover in the air, and then be inhaled by somebody at a great distance or later in time? That undoubtedly occurs. We think that those are kind of not the highway of transmission, which is close in, but those are more side streets of transmission. But it clearly does happen. Now, the virus appeared, we opened up our textbooks, looked under COVID, and the pages were blank. Since then, I think the best part of the world's response to COVID has been the extraordinary research that has occurred at absolutely every level. At the basic laboratory level, understanding the structure, function, relationships of this virus, which has of course resulted in the development of diagnostic tests and therapies, and of course, vaccines. Clinically, we've learned an enormous amount about how this virus affects both the immune system and the metabolic system that we have in our bodies. And so my colleagues in intensive care are now vastly better at caring for patients because we can anticipate some of these pathophysiologic changes. And of course, my colleagues in public health have worked to study the epidemiology of this disease, its modes of transmission, and have evaluated interventions. And I emphasize plural for interventions because, like a series of slices of Swiss cheese, each intervention provides a barrier. No intervention is perfect. They each have gaps, but the more barriers, the more slices of Swiss cheese you put together, the more likely those gaps are to be filled in. The thickest of all of these barriers is, of course, vaccines. And we were stunned that the technology, the mRNA technology that had been under investigation for 20 years, a technology waiting to be applied to a problem, was aptly applied to develop vaccines. And there were other technologies also, but the mRNA are clearly still the most exciting technologies that have been used. And when we discovered through the rigorous clinical trials that these vaccines were over 90% effective in preventing severe disease, we were ecstatic. We were a little surprised down the road that they were less effective in preventing mild disease. So you could still get infected, have mild illness akin to a common cold. You could still transmit the virus, albeit in a reduced fashion, but nonetheless, that was kind of a bit of an Achilles heel of these vaccines. Now, as the vaccines were being applied, cases diminished. We were optimistic. This was just last summer. And then along came one of these variants. The first was Delta, much more contagious, if you could imagine, than the original strain, but nonetheless, the vaccines still were very effective against Delta. I must acknowledge that certainly in my part of the country, more so than in Connecticut, the reluctance to accept vaccines has been much stronger than many of us, myself included, would have anticipated, and we're still working on that. And then once again, just as we were getting ahead of Delta, along came Omicron, yet another variant. This one a consequence of a whole series of mutations in that spike protein. Now, Omicron has certain characteristics that made it a little different than the previous variants. One is it was even more contagious. It would appear that the ability of Omicron spike protein to get into the cell somehow was accelerated by these mutations, which meant that it could reproduce very, very abundantly back in that nasopharynx. And when we shed the virus, exhaling, we would send out an even denser cloud of viruses, obviously making it easier to get an infectious dose into people who surround one. And it also may be more likely that there's more airborne transmission of Omicron simply because more virus and infectious dose can travel a larger distance. This still hasn't been determined specifically, but given the speed and the intensity with which Omicron is being spread, a lot of us think this is more likely. Not such a good thing, more highly contagious. Its second characteristic, however, was kind of a good thing. It turns out that this ability to enter cells is less effective the lower you get in the respiratory tract. And so it's less apt to cause serious disease in the lungs. I didn't say it was zero, hardly. In unvaccinated people, it can still put you in that intensive care unit. It's just less apt to do that. Third characteristic, how well do the current vaccines protect against Omicron? And the data would indicate they continue, although in a somewhat diminished fashion, to protect against serious disease, hospitalization. And however, this contagiousness of Omicron clearly indicates that even if you're vaccinated and boosted, you can get infected. You may not have any symptoms at all, or you can have milder symptoms. And so this virus has the capacity to spread not only among the unvaccinated, which is what Delta was doing principally, but also among vaccinated persons. That's either a good or not good thing. How could it be a good thing? Well, the notion is if Omicron really spreads very widely and we continue to vaccinate, a combination of the two, with overlap, of course, may get us to the point that we do reach in at least parts of the country a point where the virus finds it harder and harder to find people who are genuinely susceptible. And so new cases may indeed go down, followed by a reduction in hospitalizations, followed by a reduction in deaths. Actually, that happened in South Africa, which was the origin of Omicron. It's happening in England, and it's happening in your part of the country also. We're seeing a plateau and maybe even a slight downturn in new cases and in some hospitalizations, particularly in the Northeast. This happened very dramatically in South Africa. Big spike up, huge transmission, and quickly down. Don't think that it will happen that dramatically in the United States. We're much larger, we're much more diverse. There are parts of the country, my own included, where vaccination rates still are much lower than in other parts. So this is likely to be heterogeneous across the country. But with a little bit of luck and high hopes, cautious high hopes, perhaps by sometime in February, we might see in many parts of the country a downturn, and a downturn that could be sustained over time, which might permit us to move from, at least in the United States, pandemic to an endemic circumstance where we would have to develop some sort of truce with the virus going forward, in an analogy with what we do with influenza. So that's my fingers crossed hope for the near term. Let me see if I want to add, just touch on a few other things. Oh, one of the things we didn't do very much, we were so excited about getting this vaccine out, and public health just has a limited bandwidth, as we all do, is that we didn't put very much emphasis in our country, in contrast to Europe, on testing. Well, obviously, we've started to test, and I frankly have been surprised but gratified at the way many people in the United States have embraced testing as another mechanism, a barrier to help us deal with COVID. It's a barrier with holes in it. It's not as easy as and straightforward as it looks at first glance. If you choose to get into those details, ask me some questions. We could contrast the PCR test with the rapid tests and their utilities. But nonetheless, we're going to be seeing, obviously, testing become more part of the rather routine landscape going forward. And I think that that will help us in endemic circumstances. So I think I'll pause here and now open things up to respond to your questions, suggestions, and your corrections. Thank you very much.
Bill, thank you. And our members do not disappoint. They've already been typing. I have Dr. Ely says, thank you for joining us. But in particular, he has some questions on the accuracy and usefulness of the rapid testing methods, swabbing a tongue, mouth, and throat in addition to the back of the nose and testing that specimen. What are your thoughts?
So first of all, let's understand that when we move into using tests in the general population, by the general population, you have to be sure that when that happens, it works, it's practical. And so I believe these companies in developing these tests, and let's pause for a moment. Let's think about this, a brand new virus on the human scene, and within a year and a half or less, we had tests that could be done by the average person at home with reasonable accuracy. That's a miracle of modern science. It's a test that can be done with such reliability that one of my laboratory colleagues calls it a gorilla test. Even a gorilla can do this test. Now, to your question, do we obtain the specimen, the swab specimen, from the optimal site, which probably is back in the throat in the nasopharynx? And you will remember that the original PCR tests were nasopharyngeal specimens. They were done by a trained person. I've had those, and they go back and they're not fun, and they're a little bit hazardous. And so that obviously couldn't work in the general population. Now, I don't know what your experience is, but I've done lots of throat swabs in my day. And the way I do throat swabs is I hold the person by the back of the neck, tell them to do and then I do a medical tonsillectomy. I actually go back there and really rub the back of the throat in order to get a good specimen. If you do that, the person invariably gags, and sometimes their eyes even water. It's not pleasant. And the short answer to your question is the companies decided that individuals wouldn't do that. They couldn't be relied upon to really get a good throat specimen. So what did we do? We've gone in two directions. One is saliva. The other, much more common now, is the nasal swab, the anterior nares. That provides a reasonable specimen. And it also, as you suggest, opens up the Achilles heel of the rapid test. If you have a small amount of virus, it's an antigen test. If you have a small amount of virus, the swab may not detect the virus. The test may read negative falsely. You get a false negative result. And so if you use the rapid test, has all those advantages I just talked about, but you have to recognize, and that makes it a little bit dicey depending upon the question you're trying to answer. Particularly, am I cleared to go see grandma or go back to work? And here I want the answer to be as rigorous as possible. What's generally suggested is have a little more patience. Do a test today, and if it's negative, do another test tomorrow. And if it's negative, then we have a little more assurance that I'm not going to put grandmother at risk. Where the rapid tests work best is if you're trying to answer the question, I have symptoms, am I positive? Then, if the test reads positive, you can be sure that you've got COVID.
Thank you. Our next question is, there's been reports that nasopharyngeal irrigation can reduce infections or severity. Studies seem very limited at this point. What do you think?
Nasopharyngeal lubrication of any kind with a variety of different agents has been suggested often. The data are really anecdotal. We would say those aren't data, but they may be a reason to do a serious study. But as you say, hasn't really been studied in any systematic, rigorous fashion. And so what we say is we just don't know. If it's true, it hasn't been shown yet.
What is your opinion on the viability of this virus on solid surfaces?
The virus, the COVID viruses, can maintain themselves for a short period of time on inanimate surfaces. They start to die off very, very quickly. And the notion that we could touch an inanimate surface and then touch our own mucous membranes and give ourselves an infectious dose is thought to be much less likely. That's the reason that the CDC, although talked about that a lot initially, has downplayed the role of the inanimate environment. Is it zero? No. Has it been studied carefully with Omicron? No. So we are where we are, but I think we downplay the inanimate environment and emphasize close interpersonal contact as the major mode of transmission.
Thank you. There's so many questions. I'm trying to get that some kind of order to it, but what is the possibility of further variants that might be problematic?
Oh yeah, I'm afraid.
Do you have a crystal ball?
Yeah, but my crystal ball is totally cloudy, Tessa. But we can say with assurance that that possibility clearly exists. And obviously, that's why we must have a viewpoint that extends beyond our own borders, because variants occur when this virus multiplies. That's when the mutations occur. And if this virus is out and about in other parts of the world multiplying, that's where, by chance alone, a series of mutations can occur that would create a new variant. Now, it would become a variant of concern, and those three characteristics I mentioned would be important. The most important of which would be, is there superficial, this spike protein construction so much at variance that our current vaccines don't provide substantial protection? That would be the one that we would be most concerned about. And yes, that could happen. And then obviously, we all know what we would have to do if that also had the capacity to spread. We'd have to create a new vaccine. And yes, we'd have to start all over again. Everybody would have to get boosted with that new vaccine. This will be part of how we live with this virus, conducting global surveillance. I'd note, apropos of the global concern, every variant of concern that's occurred in the United States started elsewhere and was transported here very, very quickly. We have to take a global point of view about this.
That's very true. What about Ivermectin? There are websites that push this drug as a viable treatment. Does any data really support this drug in treating the virus?
The short answer is ivermectin is a stinker. Best studies have shown, and there have now been really good studies, one of which was led by a colleague right here at Vanderbilt, shown that it really offers no benefit in either prevention or the treatment of disease. So it's not currently recommended by the Infectious Disease Society or any other body that talks about providing treatments.
I have a number of questions about if your rapid test. Oh, sorry.
Let me just say one other thing.
Please.
That was a little brisk. You know, it's very important that we look at older drugs and could they be positioned for use. And of course, the use of dexamethasone is a wonderful example. That's an older drug we were used to for 40 years that has provided a very real role in treatment. And so a number of these older drugs have been brought up and have, in one study or another, been shown so far not to provide a major benefit. But ivermectin got a whole lot of publicity, obviously. And as the questioner says, continues to be requested by some patients in treatment and can get doctors into ethical circumstances, quandaries. So I'm sorry, Tessa, I just
No, I think that's.
I'll let everybody know I treat this seriously.
I would rather have your opinion than certainly mine on this. So, got a questions about quarantine. If your rapid test is positive, what is the recommended quarantine now, and for how long, and is retesting necessary?
Yeah,
and isolation too. Are we still recommending isolation? Okay, that was a loaded question.
So the CDC guidelines here are a little bit complicated.
Yes.
let's distinguish isolation from quarantine because a lot of us kind of blur that. Isolation happens when you have infected, you know you're infected, and you go into isolation. Quarantine happens when you're exposed. You're not sure you're going to be infected. You don't know whether the infection has actually taken place. And so you restrict your movements just in case. For isolation, what the CDC says is after 5 days, assuming you don't have any fever and your other symptoms are abating, you can leave isolation, but you should wear a mask at all times. Quarantine is divided into two groups. If you're vaccinated and boosted and you've been exposed, you need not quarantine, but you should wear the mask. If you're exposed unvaccinated, yes, you should quarantine yourself for 5 days, and then you can go out and wear a mask for another 5. Now, those were the original recommendations. Testing was not part of the algorithm. And there was a lot of pressure on the CDC. Now, the CDC did not recommend testing for 2 reasons. One was obvious, although they kind of denied it. At the time, testing materials were simply not widely available. And we certainly didn't want to create an inequity. Rich people could test themselves out of quarantine, whereas poor people could not. I mean, you couldn't possibly make that as a recommendation. But the other is that both tests have real limitations if you'd like to test yourself out of quarantine. The first, as we discussed before, the rapid test, you can get a false negative. You might still have virus, even though the test reads negative. You might not want to wear your mask then for the next 5 days. But the CDC, to cover that, said you got to wear the mask regardless of how you test. Now, what about the PCR? Why didn't we recommend the PCR, assuming it was available? The PCR is so sensitive, it can detect viral debris, pieces of RNA, for prolonged periods of time after you get better, weeks. And so the limitation of the PCR in trying to get out of isolation or quarantine is it may continue to be positive, but be meaningless and cause a lot of confusion. So neither test is ideal to test yourself out of isolation or quarantine. And that's why the CDC didn't initially recommend it.
Okay, do you find a mask recommendation? Should everybody be walking around in N95s?
I think for sure the current recommendation by the CDC is vaccinated, boosted or not. If you go indoors in a large group activity, wear the mask. And I think I continue to believe that that's correct because especially in the time of Omicron, it can infect vaccinated people and can be transmitted even among people who are vaccinated. So that's in part why the CDC, the government now, is going to make N95 masks, respirators, more widely available and distributing that. That's a whole separate story that we could go into, but at least they will become much more widely available to everyone. And then we hope that everybody wears them appropriately. As we all know, wearing them this way doesn't count, right? You have to wear it above the nose.
Yeah, I don't think I would want my surgeon to just have it on his mouth. So yeah, I can certainly agree with that. We're switching up here. How does COVID stimulate a often too vigorous I love my doctors, immunologic inflammatory cascade in some folks?
Yeah, so actually the serious aspects of COVID are different than influenza. The pneumonia following influenza is very frequently a super infection with bacteria, right? And first thought that that might be happening with COVID. Fake this out again. With COVID, you get viral dissemination throughout the body. And what really causes this bad pneumonia then is an overactive immune response that causes collateral damage. And so that's why the dexamethasone early on, as you're starting to develop the pneumonia, is so helpful because it tamps down the immune response and you don't get this overactive immune response. This a similar thing can happen with influenza, much less frequently.
Thank you. What is your opinion about family travel with a child too young to be vaccinated at this time?
That's one of the most difficult questions. The vaccine studies, I will say quickly, for children under the age of 5 are still in the works, so we don't have an answer for that yet. I mean, we don't have a vaccine for that age group yet. So what do? If we're going to do anything with young children traveling or visiting grandma, all the rest of us should be vaccinated and boosted, and then we should test those children before they visit grandma. And then I say you can do a number of things. Tell the children in advance and let grandma also know that we're going to do things to protect grandma. We're going to all be careful. And so the children can hug grandma around the waist and then back off. And just as in daycare, they'll have to put their masks back on. And then before they leave, they can give grandma another hug around the waist before they leave. And you can do things to do some separation on these kinds of get-togethers that we're having. They're not going to be perfect, but if we choose to get together, well, then let's make them as low risk as possible. By the way, I don't use that 4-letter word, safe, because that implies complete safety. I use that other 4-letter word, risk.
Risk.
Low in front of it. We reduce or lower the risk as much as possible.
Let me jump to something that is reading to me much more technical. What is the relation of B cell function and T cell function in preventing reinfection?
We don't know is the answer, but we're sure both arms of the immune system clearly are important. We're getting progressive data to show a correlate of protection on the antibody side. What level of what sort of antibody will protect you against severe disease? You know, for some viral infections, measles, we know exactly what that is. For other viral infections, for influenza, we have kind of a range and we don't have a clear correlate of protection. So we're doing that. The T cell studies, cell-mediated immunity, are much more expensive and difficult to do. We know that they have a role in protecting people. Defining that still is underway, and that work is not nearly as advanced as the B cell studies, the humoral immune studies.
Was the research on IVM done at Vanderbilt University conducted on hospitalized patients only? What is the data on the efficacy of IVM on early positive patients who are not yet hospitalized?
Now, that's Ivermectin.
Oh, okay.
It was, I believe that that's what the reference is to. It was an NIH-sponsored multi-site study. And I can't remember what the criteria were for admission to that study, but it was relatively early in the development of serious disease. So it was focused on hospitalized patients. There have been other studies that have looked smaller and some kind of large studies on other aspects of COVID, but none of them have in a sustained, rigorous fashion shown a notable therapeutic or preventive effect.
In immunocompromised patients, are they less susceptible to developing severe ARDS since their immune system is not that vigorous? Is that ARDS?
You would think that that might be the case, but as it happens, immunocompromised patients are at greater risk of severe disease. That's unfortunate because they're less apt to be able to respond to vaccines. There's now been developed a cocktail of monoclonal antibodies, 2 monoclonal antibodies that can be given to immunocompromised patients. It's not widely available yet. That might give them passive immunity for up to 6 months.
Okay.
And so some of those patients going forward, as this becomes more widely available and well known, might be protected passively, but you would have to then give them the inoculation of these monoclonal antibodies Q6 months.
I have one member who is, one attendee at least, who is disagreeing with your view of the virus jumping from animals to humans accidentally.
Sure, and it hasn't been definitively answered, and in part because our colleagues in China, as far as I know, I've not been part of any of these teams, haven't been as forthcoming as we would like. Could it have been a laboratory accident? Yes. I think everybody's pretty clear that this was not a deliberate, malicious release. That theory has been, I think, largely discredited. But could it have been a laboratory accident? Yes, that possibility is there. We then have to decide, is it very possible or is natural infection more possible? And most of my colleagues think natural infection is more possible. First of all, it happened twice previously. Furthermore, there are any number of viruses, Ebola, HIV, West Nile virus, Zika. They've all come naturally and developed a capacity to infect humans. So there's a huge amount of precedent on the natural side.
I think we have caught up with all the questions that have been typed. I'm going to ask one on my own personal interest. What do we know about long COVID?
Long COVID is another one of the ways this nasty virus got nastier. Clearly, some people either recovering from serious disease or even milder infections down the road continue to have symptoms that extend beyond 90 days. The symptom complex is pretty broad. Not every patient has everything. Fatigue is very common. Aches and pains, headaches of various kinds, both lung and cardiac limitations, and what the patients often describe as brain fog or an inability to sustain concentration on something, particularly if it's technical reading, for example, or reading anything that's a bit dense is much more difficult for them. We have a long COVID clinic that's been established at Vanderbilt. At the moment, we're providing symptomatic relief and support to these patients. And I would think similar academic centers are doing things like this and are joining together to try to figure out what is it that this virus has actually done that might lead to some of these long COVID symptoms. It's another part of the blank pages of the COVID chapter that we're starting to write and fill in as we go on.
Thank you. And I see that we have no other new questions. So if anyone has a question, we have a couple more minutes that we can hold Bill in Zoom captivity. Dr. Costa, would you wish to join us?
Tessa, I was going to say we haven't talked much about pediatrics.
Oh, let's do that.
I'm not a pediatrician. but I have friends who have
you, you're not a pediatrician, but you're playing one on Zoom today.
Yeah, there you go. And you know, one of the most frequently asked questions we still get in that arena is whether children ought to be vaccinated. And the American Academy of Pediatrics and all of my pediatrician infectious disease colleagues are strongly in favor of vaccinating children. There, the issue is the rare side effect of the vaccine called myocarditis, myopericarditis that occurs. It occurs more in adolescent and young adults. The younger you are, the less frequently it occurs. It occurs more after the second dose than the first dose, and more in males than females. Now, fortunately, in the vast majority of instances, it's a relatively mild myocarditis. Yes, some patients are hospitalized and evaluated, but they tend to get over it pretty quickly. Is there a small percentage that has kind of lingering symptoms? That's all being developed at the present time. The short answer is probably yes, but it really is very, very rare. And then, of course, you have to contrast it with what COVID itself can do to children. And it itself can cause myocarditis. And occasionally I need to remind folks that although COVID is indeed less apt to cause severe disease in children, first of all, if it's your child that's in the intensive care unit, that's 100%. But the other item is, if you look at it on a population basis, you may be surprised to learn that within 2 years, COVID appearing on the scene has become one of the 10 leading causes of death in children.
Really? Oh.
So, you know, children have very low rates of causes of death, obviously. But this new infection has crept into the top 10 list already. So you know that it happens with sufficient frequency. And obviously, children's hospitals across the country are seeing children admitted not just with COVID, but for COVID.
Do you have, or do you see any treatments that look promising now in the treatment of COVID?
Oh, one of the things I would say is one of the great research advances has been in the clinical sphere.
Okay.
Understanding the pathophysiology of this disease obviously has been very important. And so whether on the pediatric or adult side, my intensivist colleagues are much cockier now that they're able to get people out of the intensive care unit and back into a functional life. And as you undoubtedly know, antiviral drugs now are coming out of the pipeline. And what we're doing now, principally on the adult side, is if you're recently infected and you're in a high-risk group, if you're older or if you have one of a whole list of underlying illnesses, heart disease, lung disease, diabetes, immunocompromised, you can now get an antiviral drug that will reduce the transition of your disease from mild to requiring hospitalization. So these are really big advances. They're only rolling out now more widely as the manufacturer gets more medication into the pipeline. And we expect more therapies to come out of the research pipeline over the next year, year and a half.
All of a sudden, the folks are realizing we only have 5 minutes left and are typing furiously. When should healthcare workers get a 4th shot?
That has not been decided yet. And the Israelis, who originally kind of promoted that, have discovered it doesn't work as well as they anticipated. So an immediate 4th booster is, I think, not in the offing. Now, that said, is it possible that all of us going forward might have to get an annual COVID booster along with our influenza vaccine? Sure. A lot of us think that that's going to be very likely. Will we have to reconfigure the COVID vaccine the way we do with the influenza vaccine, depending on the variants out there, that's a possibility. We don't yet have the international structure that does that for flu. A lot of people on the call may not know that this is actually coordinated by the World Health Organization for flu. The construction, the composition of the influenza vaccine is decided upon twice a year, one for the Southern Hemisphere, one for the Northern Hemisphere. We could do something similar. Those discussions are already in the works. And I would also say very quickly that that some of the vaccine scientists are trying to combine the two vaccines. So maybe we'll only have to roll up one sleeve each year.
I have one more that I think I can squeeze in. What is the effect of certain SSRIs that patients on this class of drugs seem to have better outcomes? Are there any studies on that?
There are anecdotes and small case series on that issue, and it hasn't been studied in a sustained way. But that's a provocative question. It's come up more than once.
Well, then kudos to the asker, but no answers on that one.
Oh, sorry.
We only have 2 minutes left. And this one's just asking, is that with the demand on N95 masks, is there a recommendation that we can disinfect them, use ultraviolet light, microwave, boiling, quarantine?
I think
What do we do with
the best answer, rather than trying to bake them or put them under UV light and stuff like that, which we did in the healthcare environment when they were first in short supply, is take good care of them, because they can be used for a considerable period of time if they don't get misused, if they don't get crumpled, crushed, dirty, soiled in any way. So take good care of them, and when you're not using them, put them in a nice, dry, quiet place.
So
Don't stuff them in your pocket and crumple them all up.
I will stop doing that. What is your opinion regarding gain function and applying to viruses? Dr. Fauci has received much criticism from certain members of Congress.
Let's see, do we have 2 more hours to discuss?
You only have 1 minute.
Gain of function research is, can you in the laboratory create a really bad pathogen in order to study how it functions and how we might prevent it?
Okay.
I think you'll have 2 classes of folks out there who will say yes and no. And obviously the yes people would say you have to do it under extraordinary constraints. I personally, I don't know. Doesn't sound like a great idea, but on the other hand, how are you ever going to learn something about some of these bad viruses unless you study them carefully?
And we are at time. So I would like, on behalf of the Hartford Medical Society and all our attendees and the people who might be watching on video, thank you, Bill, for joining us today and sharing your information and answering our numerous questions with keeping it interesting and honest.
Great, thanks. It's been great to be with you. Stay safe. Stay low risk out there, everybody.